I am starting this new series to explain the terms used by professionals. My field of expertise is in the autism and learning disability teams, but I have some experience in dementia and mental health. Today we will look at when your loved ones is faced going into hospital or a healthcare setting. Visiting healthcare facilities can be a strange and unnerving experience. The majority of us only visit them when we are physically or mentally ill. When dealing with learning disability and or autism, hospitals can be perceived as a frightening environment within which to make sense of what is going on. Strange faces, instruments, bright lights, beeping and weird noises, people talking and screaming. If you imagine being in a crowded nightclub when you are feeling so unwell, imagine the sounds and the smell and all the people. This is just the start of the level of anxiety a person with sensory sensitivity may feel. The mere thought of it is just overwhelming. Imagine a doctor trying to talk to you in a nightclub. How overwhelmed and anxious would you be? Conversely, the training that clinical staff undergoes is really designed to prepare them for working in these high-pressured environments with people with learning disabilities or autism. Sadly, many facilities have staff that have very limited knowledge about learning disabilities and how to accommodate them. It is common for them to lack understanding of the legislative framework, and they often fail to realise an equal treatment right does not necessarily mean equal treatment, but rather might need to be adapted to meet certain needs. This is in no way a slight to the health care personnel. They go above and beyond for their patients. It is to highlight how extra training is needed to be provided to allow professionals to be able to treat the patients in a person-centred approach. So how does this all lead on to the term diagnostic overshadowing? First, let me tell you what diagnostic overshadowing is. This is when a health professional assumes that a person's behaviour is directly related to their disability without investigating other factors such as the biological factors. So an example of this would be, let's make up a name, Joe. Joe has a learning disability and finds it difficult to communicate. Joe is independent with most things when he is in familiar surroundings with familiar people who can prompt and support him. Joe's mum, let's name her Brenda, knows Joe well and knows by how quiet he is that he isn't all too well. GP advises Brenda to take Joe to the hospital where she explains her son's needs and she hands the doctor his hospital passport. A hospital passport is a book that can be made by the person or staff member who knows the person well. In it, they put all the vital information about the person, who they are, age, diagnosis, any allergies, communication needs, and any adaptations needed to care for that person. Sadly, though, in many hospital settings and some other healthcare settings, this is not a recognised document within their parameters, so therefore it is disregarded and not read. When this occurs, problems may start. I'll go back to Pretend Joe to explain. The doctor glances at the passport and continues his assessment. He's talking to Joe, asking questions while trying to take his pulse, and the nurse is trying to take his blood pressure. The word blood is obviously mentioned. To Joe, who can understand some words, this is becoming a bit scary and overwhelming. His mum is doing her best to keep him calm whilst explaining to the doctor his symptoms. The doctor hears that he's been a bit quiet lately. That to anyone else is not a red flag, so he doesn't take it very seriously. He fails to listen to Joe's mum, who tells him historically this means he is very ill. Being quiet is not a symptom, but to be sure they keep Joe in overnight. His mum asks to stay with him, but as he is an adult, she is told no and he can come back in the morning. He is independent with everything, so there shouldn't be a problem. During the night, Joe gets out of bed and starts to pace. The nurses tell him to go back to bed as walking about is not allowed on the ward, especially at night. This then has a domino effect on Joe. Joe starts lashing out, shouting and crying and hitting his own head. The doctors are called and assume his behaviour is down to his learning disability. They give him medication to relax him and get him to bed with a view of starting on some sort of antipsychotics or mood stabilisers if he continues. In the morning, his mum comes and finds Joe groggy and asks what's happened. The nurse explains he has been very disruptive in the night and the medication had been given to calm him down. Brenda is so confused. Her son is not normally like that. The doctor comes round and tells Brenda he has given Joe some medication for his mood and some medication should he exhibit this behaviour again, and Joe was discharged. Brenda tried to explain how this behaviour is not like him and something is wrong, but she is told to go home and try new meds. She gets Joe home and puts him to bed. When she goes in to check on him, Joe is pacing again. She knows Joe paces when he is in pain. It's his way of dealing with it. She asks Joe where the pain is and he points to his head. Brenda takes him back to the hospital and tells them she knows he's in pain and it's in his head. When asked how she knew that, she explained that in his hospital passport it says that Joe will quietly pace when he is in pain and wait to be asked where it is. Now one of the nurses said, well, that's strange because that's how he was last night. And when we tried to put him back to bed, that's when the disturbances occurred. He was pacing. He wouldn't go back to bed. So Joe was sent for a brain scan, where a small bleed was detected. So this is just an example of where Joe's behaviour was put down to his learning disability. He had behaviour because he had learning disability. So no further tests or reasonable adjustments were given. Should they have read his passport and listened to his mum, they would have known and allowed him to pace until he could have been taken for a scan. This is what is called a reasonable adjustment. Sadly, this happens to people with mental health and autism too, and has led to many deaths. This video is to highlight that more training is needed on how to treat everybody individually based on their own merits. Loved ones need to be listened to as they know their person better than anyone. We are losing our gut instincts over to science when most of the time it's our gut instinct that needs to do the diagnosing. So if you have a loved one that has any of these disabilities and you are not happy with what the doctor has done or said, you have to speak up. You have to say, no, that is not correct. Listen to me. I want it documented that I have said that this will happen if reasonable adjustments aren't made. Diagnostic overshadowing is a big killer in this country and sadly not many people know about it. So we need to really be brave and stand up for our loved ones that can't stand up for themselves. So diagnostic overshadowing can happen anywhere. If you have a mental health problem, your behaviour is put down to your schizophrenia, not the fact that you might be in pain. If you have IBS, your bellyache may not be because you have an appendicitis, it's your IBS. So if you know that things feel different, say so. You could save a life. Thank you for listening.